Two children, same ventilator, same oxygen, but completely different lungs, and completely different mistakes. Severe pneumonia and ARDS. They look the same, low saturation, high oxygen, alarms, but they are not the same disease. And if you treat them the same way, you will harm one of them. On the left, severe pneumonia, a local problem, uneven lung. Some areas are sick, others still work. So we adapt, we individualize. On the right, pediatric ARDS, a diffuse injury. The whole lung is involved. Now we don't adapt, we protect. Same presentation, different mechanics, different strategy. And if you miss that difference, the lung will remind you. Now we go deeper, beyond the monitor, beyond the X-ray, into the lung itself, what we cannot see but must understand. On the left, pneumonia. The disease is local. Some alveoli are filled, fluid, pus, silence. But around them, the lung is still alive, still open, still working, still trying. This is an uneven lung, part sick, part compensating. On the right, ARDS. Everything changes. The injury is diffuse. The membrane becomes permeable. Fluid moves everywhere. Alveoli collapse. Others overdistend. The lung becomes stiff, fragile. There is no safe zone. And this is the difference. In pneumonia, we work with the lung. In ARDS, we must protect it. Because here, the smallest mistake is amplified. Now, this is where it all comes together. Look at the lung. On the left, normal capacity. The whole lung participates. Volume distributes. Nothing is overloaded. Now look again. This is the baby lung. In ARDS, most of the lung is gone, collapsed, flooded, unavailable. What remains is only a small fraction. And yet, we often ventilate it as if it were normal. This is the mistake. The volume is not too large. The lung is too small. So where does the air go? Into that tiny region. Now we know the difference. Not just how it looks, not just how fast it evolves, but what the lung actually is. So the question changes. Not what settings do I use, but what am I ventilating? In pneumonia, the lung is uneven. Part of it works, part of it doesn't. So we adapt. We use volume carefully. We adjust PEEP to the patient. We treat the lung that is still. We've already seen the physiology. Now the numbers make sense. In pneumonia, 6 to 8 milliliters per kilogram is usually safe. In PARDS, the lung is smaller, so the volume must be smaller. 4 to 6, no more. Not because of guidelines, but because of the lung. Protect it. Peak end expiratory pressure is different too. In pneumonia, too much peak end expiratory pressure may harm the normal lung. In ARDS, peak end expiratory pressure is life. It keeps alveoli open. It prevents collapse with every breath. Pressure also matters. Pneumonia may tolerate it. ARDS does not. Plateau pressure must be limited. Driving pressure must be respected. Because in ARDS, pressure becomes injury. Same hypoxemia, different story. In pneumonia, the problem is shunt. The lung is filled, not broken. So the solution is simple: antibiotics and time. Yes, time still works in medicine. In PARDS, there is no time. The lung is leaking, collapsing, failing. So we escalate. More PEP, prone positioning, and if needed, extracorporeal membrane oxygenation. In pneumonia, you wait and treat. In ARDS, you act, or you are late. True, pneumonia can evolve. At first, It is local. But if the inflammatory response spreads, the rules change. This is no longer just pneumonia. This is ARDS. Now the lung is globally injured, oxygenation fails, and treatment escalates, from antibiotics to ventilation to advanced support, and sometimes all the way to ECMO. Same disease, different phase, different strategy. In pneumonia, we treat the disease. In ARDS, we treat ourselves. Less enthusiasm, more respect for the lung, because the ventilator is very powerful and the lung is not. So try not to prove it.